question when to refer a patient, a breast cancer patient, for genetic testing is a very simple question, but in actuality, it's quite complex. And so I'm going to spend the next few minutes talking about why I think that it's a little bit more intricate than just a very simple question. So as you all know, in 2017, there were an estimated 255,000 there will be an estimated 255,000 new cases of invasive breast cancer in the U.S. in women. About 5 to 10% of these cancers can be linked to an inherited gene mutation. And the risk assessment for these gene mutations is important for surgical planning, systemic therapy, and identifications of families at risk. We've known a lot about the hereditary breast and ovarian cancer syndrome for the last 30 years, and it was first described as an autosomal dominant pattern of inheritance in 1988. That was followed by the discovery of the BRCA1 gene in the early 1990s, and then followed by BRCA2, and then finally a commercial test developed by the company Myriad for assessing these genes. BRCA1 and 2 function as tumor suppressor genes. They participate in genomic stability and homologous DNA repair. Now, there are differences between the two genes. They both confer an increased risk of developing breast and ovarian cancer, but there are a little bit of differences between the two. BRCA1 is usually associated with ER-negative disease when a patient develops cancer, as opposed to BRCA2, where most of those cancers will be ER-positive, as they are in the general population. Both usually do not have HER2 positive disease. BRCA1 is often grade 3, so a high-grade, aggressive type phenotype. And BRCA2 is usually a little lesser aggressive, perhaps grade 2 or grade 3 phenotype. A second primary breast cancer occurs more frequently in patients with a BRCA1 tumor, about 2 times as more frequently. And ovarian cancer also occurs more frequently in the BRCA2 subtype than it does in, the BRCA1 subtype than it does in the BRCA2 subtype. Male breast cancer, however, occurs more frequently in BRCA2, although we do know that there are some patients who have male breast cancer and do harbor a BRCA1 mutation. And prostate cancer happens almost twice as often in the BRCA2 population at an early setting, so by the age of 65. And then there are risks for pancreatic cancer and melanoma with both BRCA1 and BRCA2. But genetic testing for breast cancer is a lot more complicated than what we know about just BRCA1 and 2. And in fact, the genetic testing looks a lot different today than it did 10 years ago. And in 2016, the genetic testing industry, so testing for genes for breast cancer and other cancers and diseases, is expected to be about a $12 billion industry just in the United States alone, and that's expected to double by over the next 5 years. And we have even some academic institutions that are getting into the game of this genetic testing. Obviously, you all know about the famous editorial that was in the New York Times by Angelina Jolie, an actress who has BRCA1 mutation, and she talked about her story of having genetic testing, finding out she was BRCA1 positive, and then deciding to have prophylactic mastectomy as a result of that. And there were a lot of people who talked about the potential Angelina effect as a result of that, how often more people would start getting genetic testing as a result of that. And actually, interesting to show that you can really get a paper published on almost any topic. In 2016, there was a paper that was published in the British Medical Journal that showed that there was a 64% increase in the rate of genetic testing as a result, or potentially as a result, of that Angelina Jolie editorial. And in fact, they even looked at the 2 weeks beforehand and the 2 weeks afterward and showed that that did influence the rate of genetic testing. So also another thing that changed the landscape for genetic testing in the United States was the reversal of the patent by Myriad, and that was done in a unanimous decision by the Supreme Court, and that invalidated Myriad's claims to patent a gene So the Supreme Court said that Myriad could not patent a gene that was found in nature. Also contributing to the changing landscape is the cost of genetic testing. So in the early 2000s, if you were going to sequence the entire human genome, it would cost about $100 million. And that has decreased significantly, falling off very significantly in 2007. And now you can sequence the entire human genome for less than $1,000. And that outpaces Moore's law for computing even. So it is a significant improvement in our ability to sequence genes, but also do so at a very cheap rate. In fact, you can have your gene sequence for $249. You can get 30 genes sequenced by a company named Color. You can spit into a little vial and get your results back in a couple of weeks. So we really have seen the direct-to-consumer marketing of this type of thing, and we as surgeons are going to be seeing a lot more patients who are going to be coming with these results. These are some of the known hereditary syndromes that are also associated with breast cancer. You know about Li-Fraumeni. There is also associated with breast cancer. There's soft tissue sarcoma, leukemia, osteosarcoma, melanoma, Cowden's disease, which is associated with the gene P10. We see diseases of thyroid, and also patients who have macrocephaly in breast cancer. We need to be thinking about potential P10 mutation or Cowden's disease. Hereditary diffuse gastric cancer, ataxia-telangiectasia, Lynch syndrome, Peutz-Jeghers, those are all syndromes that are listed and the genes that are associated with them, and also the different cancers and the various cancers that are associated with them. So who should we test? Well, the American Society of Breast Surgeons and the National Comprehensive Cancer Network actually has a very nice outline and guidelines for this. And these are being updated all the time, so you really have to keep referencing them. But the 2016 consensus guidelines from the ASBS and the NCCN guidelines from 2017 list several different criteria for who we should send for genetic testing. So specifically for a patient who has a diagnosis of breast cancer herself, if she has a diagnosis of breast cancer less than the age of 50, that person should consider genetic testing. Patients who have triple-negative breast cancer, but we increase the age to less than 60. Patients who have an Ashkenazi Jewish heritage and breast cancer of any age. If they have 2 or more primary breast cancers, whether they be in the same breast, synchronous, metachronous, and if they are in the same breast, we want them to be 2 completely separate tumors, so clearly separate tumors. Obviously, if there's a known mutation in the family, we would want to test that affected relative. And then if they have male breast cancer in the family, we would want to test. But the list goes on. So if they have a diagnosis of breast cancer and have at any age a personal history of pancreatic cancer or ovarian cancer, those patients should be considered for genetic testing. And then the rest talk about their relatives. If they have a close blood relative with breast cancer, ovarian cancer, there are lots of different permutations on this theme. So it can be quite complicated and oftentimes difficult to commit to memory. And here is yet another list. And this is where you get to, if you have 3 or more of the following of these with a personal or family history of breast cancer, then you should be considered for genetic testing. And the Commission on Cancer recommends that patients who are identified to be at risk for a gene for breast cancer and who want to have genetic testing should have genetic counseling first. And the Commission on Cancer recommends that these patients should receive that genetic risk assessment and testing through a qualified genetics professional. And that professional should prepare the patient for possible outcomes of the testing, and the implications of the testing, including any liability that may come as a result of that. The results should be disclosed along with their significance, and the patients then can make informed decisions about what to do about the management of their genetic risk as well as their breast cancer. So there are several different results that can happen when a patient is tested for a gene. First, it can come back as positive, and it can be a true positive. A true positive in a gene, like we know, can be associated with a significant increased risk of breast cancer, and that's like BRCA1 or BRCA2. And the risk for developing breast cancer with those two genes, a deleterious mutation for those two genes, is well established, and we know that there is a cumulative risk that is associated with that. However, where we start to see a little bit of muddy waters is where we start to get other results. And those are a true negative result. A true negative result might be that a family does not harbor a mutation, and that mutation has been ruled out in that individual. It's less clear how to interpret that negative result in a family where there are genes already established in CHEK2 or some other kind of low or moderate risk genes are present. And then there's the uninformative result. So what is an uninformative result? An uninformative result is when you have genetic testing and that testing comes back that there isn't a gene for a deleterious or pathogenic gene, but we don't know if there is a gene in the family. So that might be because there wasn't an affected relative for testing. Perhaps the patient's mother and grandmother both died of breast cancer and unavailable for testing. It might be that a deleterious mutation was present, but we weren't able to detect it with our current testing methods. Also, it might be that a deleterious mutation was present, but we didn't pick the right test. We didn't pick the right panel or the gene panel that included the gene that this patient may have had a mutation in. And then finally, the variant of unknown significance. And variants of unknown significance are happening a lot more frequently as more and more patients are being tested, and we have more and more companies testing and more genes being tested. The rate for variants of unknown significance for BRCA1 and 2 is only about 2.1%, and that's down about 84% over the last 10 years. And that just says that more patients are being tested, and we were able to classify those genes better into ones that are significant versus those that are not significant. And then the multi-gene panel has a wide variation in the incidence of variants of unknown significance. So anywhere from 7% to 42%, and that rate varies based on the population studies, the gene studied, or the company that was used. So a variant of unknown significance, what it tells us is that there is a gene that is identified, but its clinical significance is unclear. It could be that there is an undefined deleterious mutation. It could be just a benign polymorphism, kind of a normal change within the gene. Or it could be that there is a variant with an intermediate risk of cancer. So what about some of these other genes? Here depicted are several of the genes that have potential risks for breast cancer. On the x-axis is the frequency of which those genes occur and that are seen in the population. And on the y-axis, you can see the relative risk for how often that patient with that gene would get breast cancer. So for an example, over on the far left side, you can see that TP53 is very rare, does not happen very frequently, but it does have a significant increased risk for breast cancer if a patient has that mutation. On the other hand, you can see on the other end of the graph, a gene like COX-11 happens very frequently. A mutation in that gene happens frequently, but it has a very low risk of developing breast cancer. And in research published in the New England Journal of Medicine in 2015, there's some data from the UK where they tried to more precisely estimate risk in some of these genes. So the blue line is the risk of developing breast cancer in the general population, and that was the population in the UK. And the red lines demonstrate the solid red line demonstrates the risk of developing breast cancer related to one of these genes, and then the dotted lines are the 90% confidence intervals above and below. And so, and then relative risk is defined as high risk if the risk is above 4, and 2 to 4 is determined to be kind of an intermediate risk for developing cancer, breast cancer. So if you can see there on the left, PALB2 is a gene. It's called the partner and localizer of BRCA2. Is considered high risk now for developing breast cancer, or at least at the very least moderate risk based on the the lower confidence intervals there. And then check 2 can also be considered at increased risk, and based on this data, it looks like it's probably a moderate risk increase. And then finally, in data that was just recently presented at the San Antonio Breast Cancer Symposium in December, there was an analysis of more than 60,000 genetic testing results from the company Ambry Genetics. It was presented by Dr. Fergus Couch, and they showed that indeed PLB2 does significantly increase risk, almost as much as BRCA1 and 2 does. And then there are some others that are considered moderate risk, and then some that probably don't increase risk at all, and that we will be getting those results, and they probably don't have any significant implications for our patients. So finally, breast cancer is mostly not inherited. It's a rapidly changing landscape, and the use of consensus guidelines and consensus statements are very useful for the identification and management of women with familial breast cancer predisposition. And we should really approach the uninformative test result with caution. And then management of women who have increased risk should be considered not only just in the context of their genetic testing results, but also their family history. Thank you.